What if the very test your doctor ordered to protect you was actually putting you at risk? That sounds impossible, doesn't it? We've been taught our whole lives that more medical care means more safety, more tests, more monitoring, more early detection. It feels logical. It feels responsible. But here's what the medical community has quietly been debating for years, and what most patients over 70 are never told. Some of the most routine medical tests that seniors receive regularly are now being questioned by researchers, ethicists, and even the physicians who order them. Not because doctors don't care, but because after a certain age, the math changes. The risk of finding something and then acting on it can sometimes cause more harm than the condition itself ever would have. Stay right here, because what you're about to hear may completely change how you think about your next checkup. I want you to think about someone you know. Maybe it's yourself. A person who went in for a standard test, got an unexpected result, and then found themselves on a path of follow-up appointments, procedures, anxiety, and medical interventions that seemed to snowball out of control. You started wondering whether opening that door was the right choice. That feeling is not irrational. It's actually backed by a growing body of medical research, and it deserves a real, honest conversation. That's exactly what we do here. Welcome. If this is your first time watching, I'm so glad you found us. At Dr. Silas Redford Wellness, we believe every senior deserves the full picture, not just the version that fits neatly into a 10-minute appointment. If that mission speaks to you, please take a moment to like this video and subscribe to the channel. It helps us reach more people who are searching for honest, practical health information. We're genuinely grateful for every single person in this community. Now let's get into this carefully, because I want to be clear about something important before we go any further. Nothing in this video is telling you to skip your doctor or ignore your health. Please don't hear it that way. What we are talking about today is informed decision-making, knowing the right questions to ask, understanding that guidelines for medical testing are not always updated as quickly as the science behind them, and recognizing that what made sense at 50 may not automatically make sense at 75. There is a difference between cautious medical care and unnecessary medical intervention, and after 70, that difference can genuinely matter. Let's start with a test that almost every older American receives at some point, and one that has become increasingly controversial in the senior population: prostate cancer screening using the PSA blood test. For decades, this test was considered essential for men over 50. A rising PSA level, the protein produced by the prostate gland, was treated as an urgent signal. Find it early, treat it fast. That was the philosophy, and it sounds reasonable on the surface. But what researchers began to discover is that prostate cancer in older men behaves very differently than it does in younger men. Many prostate cancers that show up on screening in men over 70 are what physicians call indolent tumors. They grow so slowly that statistically, the man will die of something entirely unrelated before that cancer ever causes a problem. Here's where it gets deeply concerning. When a PSA comes back elevated, it sets off a chain of events. A biopsy is typically ordered. Biopsies carry real risks, including infection, bleeding, and occasionally serious complications. And if the biopsy confirms cancer, the pressure to treat it is enormous, even when watching and waiting might have been the wiser path. Treatment for prostate cancer, whether surgery, radiation, or hormone therapy, carries significant side effects including incontinence, sexual dysfunction, and fatigue that can seriously diminish quality of life. And in many cases, for men in their mid-70s and beyond, the treatment caused more suffering than the cancer ever would have. The American Cancer Society and several major medical bodies have updated their guidelines to reflect this reality. Yet millions of older men are still being routinely screened without a real conversation about whether the benefit outweighs the risk for their specific age and health situation. There was a man named Henry, 78 years old, a retired school teacher from Georgia. His routine PSA came back slightly elevated. A biopsy confirmed a small, slow-growing cancer. His urologist recommended surgery. Henry trusted the system. He went through with it. And for the remaining years of his life, he dealt with complications from that surgery that affected his dignity and his happiness every single day. His oncologist later acknowledged quietly that watchful waiting would almost certainly have been appropriate. Henry deserved to have that conversation before the surgery, not after. What doctors rarely explain is that the concept of overdiagnosis, finding a disease that never would have harmed you, is one of the most significant unintended consequences of modern screening culture, and it affects seniors disproportionately. In a moment, I'll walk you through several other tests where this same dynamic plays out, sometimes in ways that are even more surprising. The second test that warrants serious discussion for people over 70 is routine mammography for breast cancer screening. Now, I want to approach this very carefully because mammograms have saved lives, and I am not dismissing that. But the conversation around mammography in older women has shifted in important ways that many patients are never informed about. The benefit of mammography, in terms of catching cancers that would otherwise cause death, is most clearly established in women between 50 and 74. After 75, the data becomes considerably less clear. Breast cancers diagnosed in older women tend to be slower growing and more hormone sensitive, meaning they respond well to less aggressive treatments. And the downsides of continued screening, including false positives, which are startlingly common, become a bigger factor as age increases. A false positive mammogram result doesn't just cause a few days of worry. It typically leads to additional imaging, possible biopsy, weeks of anxiety, and sometimes unnecessary procedures for something that turns out to be benign tissue. For a woman in her late 70s or 80s who already manages multiple health conditions, that cascade of stress and intervention carries real physical and emotional costs. The United States Preventive Services Task Force has noted that the evidence for mammography in women over 75 is insufficient to make a clear recommendation, which in medical language essentially means the data doesn't clearly show the benefit outweighs the harm at that age. And yet many women in that age group are still being automatically scheduled for annual mammograms, often without any discussion about their individual risk or preferences. A woman named Dolores, 81 years old from Arizona, told her daughter that the anxiety she felt every year waiting for mammogram results had become one of the most stressful parts of her life. She'd had 3 false alarms in 5 years, 3 biopsies, 3 rounds of terror while waiting, and 3 times the result was benign. She finally had a conversation with her physician about stopping the annual screening and monitoring her health in less invasive ways. Her doctor agreed it was a reasonable choice for her situation. Dolores wished someone had offered her that conversation years earlier. Most seniors never realize until it's too late that they have the right to ask why a test is being ordered, what will happen if something is found, and whether they personally have anything meaningful to gain from it given their age and overall health. That is not being difficult. That is being a thoughtful, engaged patient. And it is something every person over 70 absolutely deserves. Let's talk about the third test because this one surprises people the most. Aggressive blood sugar management and its associated testing in seniors with type 2 diabetes. Diabetes management has become so standardized, so deeply routine, that questioning any part of it feels almost radical. But researchers have discovered something important. The targets that make sense for a 55-year-old with diabetes may actually be dangerous for a 78-year-old with the same diagnosis. Intensive glucose control, meaning pushing blood sugar down as low as possible, significantly increases the risk of hypoglycemia, which is abnormally low blood sugar. And in older adults, a hypoglycemic episode is not just a minor inconvenience. It can cause falls, it can cause confusion, it can trigger cardiac events, it can be life-threatening. A large clinical trial called the ACCORD study was actually stopped early because researchers found that seniors with diabetes who were pushed to achieve very tight blood sugar control had a higher mortality rate than those managed with less aggressive targets. That finding was significant enough to change guidelines. Yet in day-to-day clinical practice, many elderly diabetic patients are still being pushed toward blood sugar targets that carry real risk for them personally. Regular HbA1c testing and glucose monitoring are still valuable tools. The concern is specifically about how aggressively those results are then acted upon in older patients with multiple health conditions. There was a gentleman named Walter, 74 years old, a veteran from Tennessee. He was on multiple diabetes medications, all aimed at keeping his blood sugar as low as possible. He experienced 2 serious falls in 1 year. Both happened in the middle of the night when he got up to use the bathroom. Both were triggered by hypoglycemia. One of those falls broke his hip. His recovery took 8 months and changed the entire trajectory of his final years. His endocrinologist eventually relaxed his blood sugar targets to more age-appropriate levels. Walter never fell from a hypoglycemic episode again, but his hip never fully healed. And the worst part about situations like Walter's is that they happen quietly, without headlines, without anyone necessarily making a single dramatic mistake. Just a well-intentioned system applying one-size-fits-all standards to a body that needed something different. The fourth test that deserves your attention is routine bone density scanning, specifically when it leads to medication decisions that may carry their own set of risks. Bone density scans, called DEXA scans, are standard practice for women over 65 and recommended for some men as well. They measure the density of bones to assess fracture risk. That goal is genuinely important. Falls and fractures in seniors are serious. But here's what many patients don't know about what happens after a scan shows low bone density. The most commonly prescribed medications for osteoporosis, a class called bisphosphonates, have a peculiar long-term side effect that's been documented in medical literature for years. With extended use, typically beyond 5 years, they can actually increase the risk of an unusual type of fracture in the thigh bone called an atypical femoral fracture. The very medication given to prevent fractures can, in some long-term users, contribute to a different kind of fracture. Additionally, bisphosphonates have been associated with a rare but serious condition called osteonecrosis of the jaw, which involves tissue death in the jawbone, most commonly triggered by dental procedures. This doesn't happen to everyone, but it happens to enough people that major medical organizations have updated their guidelines to recommend drug holidays, meaning planned breaks from the medication, after a certain number of years. Many patients on long-term bisphosphonate therapy have never been told about this. Their bone density is scanned, their prescription is renewed, and the conversation about reassessment simply doesn't happen. Now, I want to be clear. If your doctor has recommended bone density screening and medication for osteoporosis, please do not stop on your own. Talk to your physician about whether your current treatment plan has been reassessed recently, how long you've been on the medication, and whether a drug holiday might be appropriate for you. That is the kind of proactive, informed conversation this video is designed to help you have. The fifth test we need to discuss is a broader one, and in some ways the most important. It involves cardiac stress testing and aggressive cardiovascular screening in seniors who have no symptoms and are considered low to moderate risk. The instinct to monitor the heart closely as we age makes complete sense. Heart disease is the leading cause of death in older Americans. Vigilance feels like wisdom. But the research on routine cardiac stress testing in asymptomatic seniors, meaning people who feel fine and have no specific warning signs, tells a more complicated story. Stress tests are not perfectly accurate. They produce a meaningful number of false positives, particularly in older women. A false positive stress test often leads to cardiac catheterization, which is an invasive procedure with its own risks, including bleeding, arterial damage, kidney damage from contrast dye, and rarely stroke or heart attack caused by the procedure itself. When a patient goes into a catheterization lab healthy and comes out with a complication, that is a harm directly caused by the medical system's attempt to find a problem that may not have existed at all. Several major cardiology organizations have moved away from recommending routine stress testing in low-risk, asymptomatic older adults for exactly this reason. There is a woman named Evelyn, 73, from Michigan, whose annual physical led to a stress test her cardiologist described as precautionary. The test came back borderline. A catheterization was recommended. During that procedure, she experienced a small arterial tear. She spent 3 days in the hospital and 6 weeks recovering. Her follow-up showed no significant coronary disease. She was healthy going in. She was less healthy coming out. Evelyn is not angry. She understands the intention was good, but she wishes someone had told her that the procedure she agreed to had real risks attached to it, and that her actual risk of having a serious cardiac event was already quite low. So what do you do with all of this? How do you walk into your next appointment as an informed, empowered patient without becoming adversarial or paranoid? It starts with a few simple questions that you absolutely have the right to ask. Ask your doctor, what are we looking for with this test, and what will we do if we find it? Ask, given my age and current health, what does the research say about whether I personally benefit from this screening? Ask, what are the risks of this test and the treatments it might lead to? And ask, are there alternatives to this approach that might carry less risk for someone my age? These are not confrontational questions. They are the questions of someone who is engaged in their own care. And any physician who values your well-being will welcome them. If they don't, that's important information too. You have spent decades being told to trust the system, to follow the schedule, to show up for every test and every screening without question. And much of that guidance came from a good place. But you are not a statistic. You are not a protocol. You are a specific person with a specific body, a specific history, and a specific set of values about how you want to live your remaining years. The decisions you make about medical testing should reflect all of that. There is something deeply empowering about walking into a doctor's office and having a real conversation instead of just nodding along, about saying, help me understand this test, about advocating for yourself the way you would advocate for someone you love. You deserve that. You have always deserved that, and it is never too late to start. Small changes in how you engage with your healthcare can make a meaningful difference in your quality of life. Not dramatic changes, not dramatic declarations, just a little more curiosity, a little more advocacy, a little more insistence on being treated as the intelligent, experienced adult that you are. If today's video gave you something to think about, or if you've had your own experience with a test or treatment that didn't go the way you expected, please leave a comment below. Your story matters. It might be the thing that helps someone else feel less alone, less confused, or more confident walking into their next appointment. This community is built on real conversations, and I read every comment. And if you have a friend, a sibling, a spouse, or a neighbor over 70 who you think might benefit from hearing this, please share this video with them. It costs nothing, and it might genuinely make a difference in how they approach their healthcare. Thank you so much for being here. Take good care of yourself, ask good questions, and I'll see you in the next one.